Good afternoon. I think everybody want to just leave. It will be short and informative. The vitamin D, maybe everybody is thinking that the rickets is finished and from 70s, 80s, no more rickets, but it is coming back. I was before 6 months in the refugees in the border between Turkey and Syria, and we saw a lot of children and mothers with malnutrition, including vitamin D deficiency, severe iron deficiency anemia, and other than the trauma what our doctor presented in the previous and this presentation. Away from H1N1, what our colleague also mentioned, I think vitamin D is not killing the newborn or the infant or the mother, but the quality of life, especially for those ladies who's giving birth for 8 babies, 10 babies. Pregnancy and breastfeeding will wash the bone from the calcium, and by the age of 40, 45, or 50, they have started complaining, oh, my back, oh, my knee, my leg, and they shrink. So it's very important to supply the mothers and the newborn baby with the vitamin D. And our colleague yesterday, she mentioned about nanotechnology of the medicine in general. And we know that the newborn baby may not, or the infant or the children, may not taste the vitamin D and they may vomit it. Or the mothers may give an extra 1 drop, 2 drop, 3 drop. So if you provide the vitamin D through the maternal breast milk, will be much better and more compliance. So our study is randomized controlled trial of vitamin D supplementation of lactating women to prevent vitamin D deficiencies in mother and the baby. And this is in affiliation with the Cincinnati University. Professor Dr. Dawood is international pediatric epidemiologist. And the study is sponsored by Qatar National Research Fund. This is charity, non-profit organization. It support the research in Qatar and in all over the world, but affiliation with Qatar University, Qatar Hospital, and Qatar Hamad Medical Corporation. So when the woman is deficient in vitamin D, her developing fetus is deficient. And similarly, lactating women who is deficient in vitamin D provide breast milk that is deficient in vitamin D also. Therefore, unless her breastfeeding infant is supplemented, her breastfeeding infant will be deficient. Vitamin D supplementation of the mother with the high doses improve maternal vitamin D, and so doing increase her milk anti-rachitic activity and thus transfer of vitamin D to her nursing infant. They also showed both efficacy and effectiveness. So what needs to be shown is safety and effectiveness on larger scale. So the vitamin D deficiency rickets is mostly reported worldwide among breastfeeding infants who lack exposure to sunshine or vitamin D supplementation. Despite that, in Qatar and in the Gulf area, the sunshine is all over the day during the year, so we don't have like here and in Europe that maybe 6 months cloudy weather, no sunshine. But the problem that the temperature is reaching 50 degrees in July and August, so nobody can be exposed to this sunshine. And the second point also, the tradition that the ladies are wearing what we call it abaya, they covering the head and the face sometimes, so even they cannot reach to the sunshine. And the third thing is also the type of food what they are taking. It is all over the world, not only in that area of the world, that it is junk food, it is not a healthy food, whether the mother is pregnant or breastfeeding, so the child will be also deficient of vitamin D. So our objective is to examine the effectiveness of high dose of maternal vitamin D supplementation. Instead of 600 units, we'll give 6,000 units per day for the mothers alone versus current recommendation of direct maternal supplementation. The mother will take 600 and the baby will take 400. So the mother who receives 6,000 units, the baby will receive placebo, and the mother who receives 600 units, the baby will receive 400 units. So high dose, 6,000 units per day maternal supplementation alone can maintain the serum vitamin D level of her infant equivalent level that infant on current direct supplementation with 400 international units. Through increase in human milk content with no difference in safety and measure. So the maternal serum 25 OHD level at least 4 weeks after delivery, then 4 months and 7 months postpartum, and the monthly we are monitoring the urine calcium creatinine ratio in the mother. Infant serum level and serum calcium at 4 weeks, 4 months, and 7 months postpartum. A healthy woman with singleton delivery and were eligible to be precipitate. Exclusion were diabetes, hypertension, triplet, twins, or if the mother already on vitamin D supplementation. Monitoring for effectiveness and safety. Serum vitamin D, PTH, 4 weeks, 4 months, and 7 months postpartum. So maternal urine creatinine, calcium creatinine ratio at monthly interval, adverse events record and reported to Data Safety Management Board. So administrative secretary, who is not involved in the study, assigned the randomization code generated by the computer to each case. Only case number appear on the case report form. The chair of Data Safety Management Board may have access to the code. The investigators and health team will be blinded to different treatment till analysis finished. So this is the algorithm, how we can give the vitamin D. As I mentioned, there will be 80 mothers and 80 infants will receive 600 units, the mother, and 400 units for the baby. On the other hand, in the group 2, the mother will receive 600,000 units and the baby will receive placebo. So total will be 160 mother and 160 baby, plus the monitoring of calcium creatinine ratio and PTH. Vitamin D supplementation for the mother with 6,000 units only versus maternal 600 plus infant 400. Follow up infants and mother complete questionnaire. So we designed questionnaire where we take the history, nutritional history, how many hours per week they are exposed to the sun, and what type of clothes, if they are covering their face or hand or wearing abaya. So, and the analysis of the result and preparation of the report. So we determined vitamin D status at enrollment started August 2014 in first 107 consecutive mother and infant participating in randomized control trial. We have problem with the exclusion criteria because some of them, they are giving just breast milk for the first month, 2 months. So the mandatory, they should continue on exclusive breast milk for 7 months, and exception maybe 1 to 2 bottle feeding can be given, and also this will be captured by the questionnaire. And all of these mothers are Arab mothers who delivered a term, more than 37-week gestation, and plan to provide predominant breastfeeding at least 6 months, were enrolled at 4-week postpartum. Data were collected on maternal and vitamin D supplementation, time spent outdoor in direct sunlight and body service area, exposed while outdoor table, we'll see it later. Primary outcome were maternal and infant serum. Comparison was made of sun exposure, vitamin D supplementation, and vitamin D status with breastfeeding mother study in Cincinnati, Ohio, at similar postpartum age and season. And this is the okay, so this is the response about the covering of the head, whether yes or no, and the body service area according to the measurement percentage. And this is the vitamin D level basic of the mother. So we have around 20, they have less than 20 nanogram, and from 10 to 19 nanogram is 60, and from more than 20 to 29 is 21. And more than 30 nanogram is 2. So this is almost around 78% is severe deficient mother, and 20% is severe deficient mother of vitamin D. Down, you'll see the vitamin D level in babies, basic in babies, which it is more severe than even the mother. So vitamin D level basic of mother in the visit 1. The group A is 64 mother, and group B is 66 mother. Average vitamin D is 14, which it is moderate deficiency of vitamin D. Again, basic level in the first visit for the baby. Group A is 65 and group B is 66, and the average vitamin D level is 11. So we have the average vitamin D level of mother on visit 2, which it is 4 months after giving the vitamin D. So group A is 28 for the mother, and group B is 27. And the baby, the group A is 31 and the group B is 32. Despite that, in the first visit, the baby is more deficient than the mother. In the second visit, both group A and B in babies, the vitamin D level is higher than the mother. So this is the category of vitamin D status at 4-week postpartum. So milk vitamin D content was measured using LS-MS and serum 25-OH concentration by Celia. Milk vitamin D were categorized as, and it is, I think, by the way, the only 1 or 2 lab in USA doing this vitamin D in milk, and it is very expensive. Each sample is $100. So it is categorized below assay detection, less than 8.2 international unit per liter, below normal range, 8.2 till less than 20, and within normal range, more than 20 international unit per liter. So serum 25-OH less than 50 nanomole per liter was defined as vitamin D deficient. So the main standard deviation, maternal milk vitamin D level was 12.6, and the prevalence of maternal vitamin D deficiency was very high, while maternal sun exposure was very low and diet vitamin D intake was low. 75% of the mother have milk vitamin D level below assay level, below detection at 4-week postpartum. Serum 25-OH were significantly lower in mother with milk vitamin D below assay detectable level than those with milk vitamin D above detectable level. maternal serum 25-OHD correlated with maternal milk vitamin D, and it will be significant 0.004. There were no correlation among milk vitamin D content and maternal age, education, vitamin D intake, and sun index score. Again, this is also maternal sun exposure. So the result, mean serum 25-OH is 27.9 nanomole. Overall, 84% are categorized as deficient and over 60% severely deficient. Serum 25-OH concentration correlated with maternal vitamin D, and significant, it is 0.001. A negative correlation between vitamin D and PTH was insignificant, and none of infants had received vitamin D supplementation or had been exposed to sunlight. So in conclusion, severe vitamin D deficiency is more common in infants than mothers in sunny environment. Low maternal vitamin D status is associated with low sun exposure and vitamin D intake, where speculated that low vitamin D status in infant is related to low status at birth, aggravated by no sun exposure and vitamin D intake. Vitamin D supplementation of the mother and infant would help to prevent deficiency. And this is the theme of the study. Thank you very much. Yes.
So the initial question was the really high supplementation in mothers good or equal to supplement the mother and the baby at low levels? What did you find?
I think if you, as our colleague yesterday, when she talked about nanotechnology, I think it's much better the baby to receive vitamin D through maternal milk rather than to give the drops, because the drops, the compliance is low, and the baby may not like it. He may just vomit it. The mother may give an extra drop to make sure that he took it. So I think it's much better to give the mother high dose of vitamin D. It will help her to prevent vitamin D deficiency in herself, because almost the calcium and vitamin D has been utilized during the pregnancy, and if she is giving exclusive breast milk, so it will help her to keep normal vitamin D level for herself and for her baby. And really, when you go, this is, for example, in Qatar, where the standard of life and maybe one of the highest country in the income over the world. When we went to the refugees camp, it is horrible. It's really horrible. Some children, they are even the one who is not injured by the strike of the airplane and the bomb and all these things, they have deformity of lower limbs because of severe deficiency of vitamin D and calcium and malnutrition. Okay.
Thank you so much.
Thank you very much.